How would you treat your cardiogenic shock patient coming in through the front door? You get your phone call in the middle of the night that you're very pleased to receive with your STEMI with cardiogenic shock. What's the priority in Glasgow? What order do you do things in?
Well, we're fortunate in some respects that we work in a hospital that has a mechanical circulatory support service, although it's primarily based on ECMO and VAD, not Impella. And we've got a fantastic ICU support. So, to some extent it depends on, what sort of STEMI it is. I wouldn't call the ICU guys straight off for somebody who came in with a big inferior, who was in complete heart block and, had a pressure of 70, because I would have a high expectation that if I open the blocked right coronary, they're going to improve. And of course, if you activate the whole system for somebody who, by the time the team arrives, is actually doing quite well, then you don't want to really be doing that, especially not out of hours on the weekend and so on. Of course, a left main occlusion or a very, very proximal LED occlusion with a big anterior infarct, those are the ones where I would be almost certain that opening the LED alone is not going to fix it. So generally what we do with those is we put the balloon pump in and get the radial access to do the primary PCI pretty well simultaneously. Mm-hmm. Now, of course, we accept the randomized control evidence that balloon pumping overall doesn't seem to improve mortality in these patients. But I think everybody understands there are some issues about timing, that the balloon pumps in the IAB shock, AP shock trial may have been put in too late. And also there is an issue about being able to use less of the toxic vasoconstrictor inotropic drugs than might be the case if you didn't have a balloon pump. And then ultimately, if the MCS starts to turn up in the cath lab and we haven't put a balloon pump in, they're going to ask us why. Yeah. So we still almost always will go with the balloon pump. And then my own preference is, even after the LED's open and we've got good flow, you have to just sit in the cath lab for a little time, because it's often the reperfusion injury that tips these patients back into cardiogenic shock. Yeah. You see this transient improvement, the ST segments may even come down, and then as the reperfusion injury starts to hit the myocardium, the ST segments go back up again, the vessel's wide open, but actually the patient's not improving.
So your cardiogenic shock patients do come straight to the cath lab, like just a primary activation as normal, not necessarily the ICU team there unless they're in extremis or they're in out of hospital arrest, essentially.
Only if they're essentially still in arrest. If they're being massaged along the corridor from the ambulance, then sure, the ICU team would already be there. We would have an intensivist meeting. They would meet the patient at the front door.
Yeah. I mean, some degree of early assessment is quite important. There's this sweet spot between not doing anything for too long and doing something too quickly. But I think you have to assess the patient, and I think, what impression I get from Keith here is the right one, that they come, you assess the situation. A balloon pump is acceptable despite IABP2, which showed complete similarity and overlap of the survival curves, although there was some criticism of that trial for low risk cardiogenic shock patients. I think that assessment period is really important, and Keith's absolutely right. I mean, calling all the intensivists and anaesthetists down to the cath lab and then the patient picking up is not a good thing to do. At the same time, sending them back to the ward and finding at 4 a.m. they're still running a blood pressure. We're still coming in the next morning and finding that blood pressure's been 70 all night. It's too late.
An oliguric, absolutely. Yeah. I mean, so would you tend to take these patients back to your coronary care, but with some critical care outreach going in there? Or I'm just trying to get a feel for how then your person who you're worried about their reperfusion injury with their left main stem occlusion that you've managed to rescue them from, where are they going next? Are you sort of like, right, they're going to ITU, or are you looking after them on CCU? And where are you taking them from there, and how are you getting them?
Echo them in the cath lab. Yeah. And then we would get the ICU guys to come down. Yeah. And we would be delighted if the ICU guys were happy to take
Ever
the
had
patient.
any beds?
If they had any beds. Of course, if the patient isn't ventilated,
Yeah.
they might end up going to CCU rather than ICU. But even in a patient who's not ventilated, our ICU guys are very, very good. They're usually happy to take these patients. If they even get the slightest hint that there's going to be some escalation, you know, to ECMO or in our case it would have to be a VAD, then they would just go to ICU anyway. So we are very, very fortunate in that respect. And then, of course, you know, that you have the problems about trying to adjust the hemodynamic support with, you know, various inotropes and vasodilators, which, of course, a lot of the time the ITU guys are used to using them in the context of a post-operative patient.
Or a septic patient.
Yeah, but for a cardiogenic shock case who's just had a big anterior infarct, that's not necessarily appropriate. So ideally, I would say ICU.
Because in our non-surgical centre, we try and keep them on CCU actively because we're worried about the use of sort of escalating inotropes and their lack of familiarity with balloon pumps, quite frankly, in a non-surgical centre. So we tend to try and keep them on coronary care unless obviously they're ventilated. What sort of inotropic support do you use? I sort of use a bit of phenylephrine in the cath lab just to sort of get them through that initial period. But, you know, obviously because of sepsis and the post-op patients you mentioned, our ITU colleagues are very keen on NORAD quite often. So I'm just sort of wondering what your inotrope usage is like. We didn't really touch on that this morning.
It's all of those, but, you know, what I think we have to understand is that the need that a patient has to be on intravenous supportive drugs is a predictor of poor outcome.
Yeah. So,
you know, we'll talk about trials later on and you have to decide what is cardiogenic shock. But if you're requiring lots of inotropes and other agents to keep this patient hemodynamically out of so-called cardiogenic shock, then that really is a failure of drugs in a way.
Yeah.
And although it may keep the patient going, those patients have a poor prognosis. I'm not saying it's not the right thing to do. I'm just saying one shouldn't fool oneself that the patient has now got a better prognosis because they're just being held with lots of inotrope.
Yeah, because the registry data tells us that, doesn't it?
Yes, it does.
Yeah.
Hence, wanting to have something that actually can enable you to reduce the need for inotropes. So if less you're able to use inotropes, it's because if you see that increases your contractility, that means energy. Energy means more oxygen that you need, and it becomes a vicious circle.
Yeah. We did talk a little in your talk this morning about drugs being used in cardiogenic shock, particularly in the setting of infarcts, where you get no reflow, and that is your sort of drive for cardiogenic shock. Did you want to just mention that briefly, maybe?
I mean, I did show a slide that suggests there have been no drugs that have shown benefit in other than the standard inotropes in terms of trial data. I mean, that doesn't mean you shouldn't use the drugs we use already, but the fact is that we still have a 40 to 50% mortality for patients. Now, you know, some patients will die no matter what, and some patients will survive no matter what. And one of the real challenges is working out who's going to survive and who it's futile, and compassionate care may be more appropriate. And that's one of the real issues, I think. You know, is somewhat should be tailored smart medicine to try and find out which factors. And there are quite a lot of data out there of predictors of outcome. In fact, we've just published an editorial European Heart Journal.